Welcome to our clinical explainer on BPPV. Today, we're zeroing in on the two most crucial bedside maneuvers you need to know, the Dix-Hallpike and the supine roll test. Let's get right into it.
Okay, so think about this for a second. The Dix-Hallpike is our gold standard, right? But it can fail in up to 20% of patients who absolutely have BPPV. So what's going on there? Well, as we're about to see, the problem usually isn't with the test, it's with the tester.
So let's start with the big one. This is our go-to diagnostic test for posterior-canal BPPV. And since that accounts for up to 90% of all cases, mastering this maneuver is non-negotiable.
Now, technique here is everything. Precision is absolutely key. You can see the 5 steps laid out, but I really want to focus on step 2. That movement has to be quick, and you must get the head to that 20-degree extension below horizontal. That's the move that gets those little crystals, the otoconia, moving, and it's what provokes the signs we need to see.
And this right here, this is probably the single most common reason for a misdiagnosis. We call it premature termination. The classic nystagmus, the eye movement we're looking for, can actually take 5, sometimes even 10 seconds to show up. So if you stop looking too early, you're going to miss it entirely. You have to watch their eyes for at least 30 seconds, but honestly, a full minute is even better.
Okay, so performing the maneuver is one thing, but knowing what you're looking at, that's the other half of the battle. This is where you separate a straightforward BPPV diagnosis from something much more serious. Think of it like a fingerprint. A positive test for posterior canal BPPV has a very specific signature. It's not just any old eye movement. You're looking for this exact combination. First, a little delay, then a nystagmus that is both upbeat and torsional. It should last less than a minute, it should get tired if you repeat the test, and they'll actually flip direction when the patient sits back up.
And this is absolutely critical. We're not just talking about getting the diagnosis right. We're talking about patient safety. If you see a pure downbeat nystagmus, especially one that starts immediately with no delay, that should be a massive red flag. You need to be thinking about a central neurological issue, maybe a cerebellar lesion.
So, think of this table as your go-to cheat sheet at the bedside. It puts the classic BPPV pattern right next to those atypical red flag findings. Just remember, any nystagmus that's persistent, doesn't get tired, or is purely vertical means you stop, you reconsider, and you investigate for a central cause.
So what happens when the test comes back negative, but your gut is just screaming BPPV? Well, before you doubt the diagnosis, check your technique. These 3 things are by far the most common culprits. And if you have a patient whose neck issues are getting in the way, don't forget, the sideline Semont test is a fantastic alternative. That brings us to the next logical question, right? You've got a patient with a textbook history of BPV, you do a perfect Dix-Hallpike, and you see nothing. It definitely happens. And when it does, we just need to pull a different tool out of our toolbox. The answer? You've got to test for the second most common variant, which is lateral canal BPPV. It makes up about 10 to 15% of cases. And the Dix-Hallpike, well, it's just not designed to pick it up. You need a different test. And this is where the supine roll test comes in. It's specifically designed to target those horizontal or lateral canals. Now, the technique itself is pretty straightforward, but the key here isn't just seeing the nystagmus. The real diagnostic clue is in comparing its intensity and its direction when you turn the head to one side versus the other. Okay, interpreting this one can feel a little tricky at first, but it all comes down to which way the eyes are beating. The most common thing you'll see is geotropic nystagmus, which means the eyes beat toward the ground. In that case, the side with the stronger nystagmus is the affected side. Simple enough. For the less common apogeotropic type, where the eyes beat away from the ground, the rule is just flipped. It's the side with the weaker nystagmus that you need to treat.
All right, we've covered a lot of ground. So let's boil it all down. What are the absolute most critical practice-changing points that you need to walk away with?
If you remember nothing else from this explainer, remember these 4 things. First, use both tests. Together, they'll catch over 95% of cases. Second, be patient. Hold each position for at least 30 seconds. Third, know the classic pattern inside and out. And finally, and most importantly, know when to stop. Recognize those red flags and don't epley. That right there is the foundation of safe, effective BPPV diagnosis. So you've nailed the diagnosis. What's next? Well, That's where the real magic happens, the treatment. And that's exactly what we're going to cover in our next explainer. Join us as we walk through the Epley and Guffoni repositioning maneuvers, step by step. So I'll just leave you with this final thought. Mastering these two simple, hands-on maneuvers can fundamentally change your practice. It can transform BPPV from a frustrating, confusing complaint into one of the most satisfying in-office cures in all of medicine. Thanks for watching.